Hello, everyone. Welcome back to our AOCPMR podcast. My name is Shahana Momin, and I'm a current third year, and I'm currently a co-chair for the AOCPMR Student Council Public Relations Committee. I will be the host for the podcast today. And with me here, we have Dr. Andriana Tompary. Welcome to our podcast, Dr. Tompary. It's my pleasure to host you. And thank you so much for being here.
Thank you for having me.
Yeah, of course. Before we go ahead with some questions, I just wanted to do a quick introduction about you to our audience. Is that okay with you?
Absolutely.
Okay, perfect. So Dr. Andriana Tompary grew up in the northwest suburbs of Chicago. She completed her undergraduate degree in psychology at Loyola University Chicago. She then completed her degree in osteopathic medicine at Marian University College of Osteopathic Medicine in Indianapolis, Indiana in 2019. Currently, she is a second-year resident at the University of North Carolina at Chapel Hill, and her professional interests include neurorehabilitation, spasticity management, and spinal cord injury medicine. In her free time, Dr. Tompary enjoys hiking with her fiance, John, and her two dogs, Ben and Olaf. She is also an avid ultimate frisbee player. Very cool. Is this information correct in describing you, Dr. Tompary?
Yeah, absolutely.
Okay, awesome. All right, so thank you again for being with us today. We're going to go ahead and get started with the questions. In this podcast today, I'll try to explore your journey in matching into PM&R, as well as talk to you a little bit about your current residency program and any advice that you might have for the future generation. So, are you ready?
Right, let's do it.
All right, first question. How did you know about the PM&R field when you were a medical student, and could you describe your journey in discovering and matching into this specialty?
It's a great question. I think everybody's journey, obviously, into PM&R is unique. I had heard about PM&R as a medical student. I had the opportunity to shadow some PM&R physicians back when I was an undergrad. Honestly, though, going through medical school, I thought, I wanted to be a neurologist. I thought like neuromuscular diseases were really interesting to me. And so that was kind of what I thought I wanted to do. And so going throughout third year of medical school, I was kind of waiting for that neurology rotation and really liked kind of almost all my rotations. There are pieces that I liked about everything. Obviously, wasn't a big fan of surgery just from the hours and kind of workload with work-life balance. But found myself just kind of, happy overall. It wasn't until kind of going into fourth year, that summer going to fourth year, that I was like, oh gosh, like, what am I going to do? I can't figure this out. And I was drawn, I think, in general to, the musculoskeletal system as a whole. And I kind of just sought out some classmates. So Nevin, who Dr. VJ, he's a fourth year resident at UNC as well. He also attended my medical school. And so he always kind of laughs when I tell the story, because he's like, oh, here we go again, talking about me. But I sought him out as a mentor because I knew he was going to PM&R, and I was just like, I need to talk to somebody about my interests and what I like and what I don't like. And what I found with my neurology rotation was, we would diagnose and see these really cool pathologies, but it was kind of what after. Now, what does this mean for the patient, for their family? How are they going to get back to their day-to-day life? What does this mean for them going forward? And so when I met with Nevin, I kind of expressed that to him in general, and he was like, Andy, like, come on, you need to do rotation in PM&R. Like, this is screaming PM&R to me. And so I was like, oh, duh, the light switch kind of went on then. And I was like, okay, all right, let's do that. So for me, it felt like a little bit of a scramble in a way, because I was going into fourth year. I hadn't done a rotation. So I, pursued a rotation in Indianapolis, kind of reaching out to other PM&R physicians in the area. And I had one that was willing to host me. And fortunately, he did kind of a big, broad kind of PM&R stuff. So he did some pain, MSK clinic, also did EMGs, and also staffed an inpatient rehab unit. It was a smaller unit in general, but we mostly saw mainly strokes and spinal cord injury patients. So it gave me a good month just to see kind of the bread and butter type of things. And immediately kind of within that first week, I was like, oh, this is it. This is home for me. This is what I want to do. So that was kind of the start, so to speak. So again, kind of later to the game in general, and then, applied and kind of did my thing. Because I did the rotation August going into, I guess, my fourth year of medical school, I ended up not pursuing any away rotations, just because by that point, VSAS was all full. I thought maybe I was going to go the neurology or family med, sports med route. And so my auditions were kind of set in that pathway. And, by that point there were rotations available that following February, which would have been kind of after interviews had been all set up. So, made it work with that rotation in general and kind of networking within the PM&R community. It worked out well for me. I know it's can be nerve-wracking not having necessarily like the audition rotations, especially, in this year too, with students applying that they're kind of in that similar boat. I guess my experience is what I'm trying to say is kind of mirroring what a lot of the students are going through right now. So for me, it worked out. I got, adequate interviews. I was kind of happy with the process, and it worked out. I matched it, my top program, and I'm very happy.
That's awesome. Yeah, UNC Chapel Hill is amazing. So that's really, really awesome to hear. PM&R is a really diverse field with diverse subspecialties, and you kind of mentioned a little bit of your specialty interests when we discussed your bio, but I was wondering what your specific interests right now are in the field of PM&R, and what made you focus more on these specific topics in PM&R?
Yeah, it's a great question. I think, obviously, like I was saying before, a lot of people I think are drawn to PM&R because of that MSK kind of background, so to speak, and you kind of forget about all the other subspecialties. I found myself so far in second year really, really liking inpatient medicine, which a lot of my co-residents are like, think I'm, a little crazy for loving it. I like the idea of being able to kind of work directly with the team. So we have our nursing staff, our nursing aides, speech therapists, occupational therapists, physical therapists, the rec therapy people, as well as our neuropsychologists, everybody. So, we're there kind of with that sole focus of working with not only the patient, but the patient's family. Overall, I kind of was drawn to that inpatient side. And I actually found myself really enjoying spinal cord injury medicine. So, we do see a lot of patients with these big life-changing events, and kind of, working with them through that journey of, okay, this is the event that happened, but how are we going to get you to relearn your kind of day-to-day life and get your family to kind of help you assist and, reintegrate into community and all those things. So I fell in love with the medicine side of that as well, just because of, spinal cord injury patients are kind of special and they have their own kind of medical complications. And found myself kind of needing to be more of an advocate for them, not only like in the community, but also in the hospital setting as well. So kind of fallen in love with that area. Within inpatient medicine, I do kind of like the neuro rehab as well, dealing with kind of the strokes and TBI type patients, as well as spasticity management more in the clinic. But kind of didn't see myself going down the spinal cord injury route in general. Thought, maybe I'll do sports and kind of go that, route. But really the inpatient side for me is kind of what caught me by surprise. And I'm looking at possibly pursuing fellowship in spinal cord injury after training.
Okay, awesome. And on that note, what are some of your favorite moments as a PM&R resident that kind of helped reaffirm your aspirations to becoming a physiatrist?
Oh gosh, there are a lot. I think, oh man, I think in general, the first thing that struck me when I was a second year, again, kind of coming on inpatient medicine, which this is going to sound a little strange because you kind of take these things for granted, but seeing a patient, after they've had a shower for the first time, it sounds strange, but some of these patients are in the hospital for weeks and weeks and weeks, and they haven't had a real shower. So, seeing them on the inpatient side and working with, our occupational therapists, and they get that first shower and they're like a renewed person, like their whole affect tends to change. So that in general is always like kind of transformative and great to see. Those are kind of the little moments I like. But one of the, I think, big moments that I had a couple months ago was, with a patient that we had who had some aphasia, after having a stroke, and we found out that he, was an avid guitarist and music player, kind of pre-injury for years, his whole life. So we ended up finding a guitar on one of our other units, our cancer rehab hospital, and bringing that in for him. And his wife brought in some of his old music, and he just started playing. And, you wouldn't have thought that he had kind of the injury that he had sustained, essentially. And it was so great to see, because he just kind of lit up we were all just kind of crying. It was beautiful, seeing him just kind of have a piece of his, life that was still there for him, and really important for him to be able to do, that he was able to still do as well. And I think the last thing is also just, for the most part, how excited patients are to come to rehab, because they're like, okay, I'm getting closer to getting home. So when you're telling them, yeah, we might admit you to rehab today, they're like, oh yes, please, take me, I want to come, because people don't want to stay in the hospital. They want to get back to their day-to-day thing. So it's nice because, you're the doctor that patients kind of want to see sometimes.
Yeah, I think that's one of the things that's really struck me as even a student is that all of our patients are so motivated. And it's just about, those are very like wholesome, touching stories that about even just the shower. I can imagine just, a small moment that a patient can get back, and the form and function and the guitar playing, that's a big moment. That's like a passion that they can still pursue. That's really awesome that you guys were able to help him.
Yeah, it's
Yeah.
it's it's always humbling, I think, because
Yeah.
again, we take things for granted. I think all of us do naturally, just by what we're able to do, and seeing that kind of taken away from people and then kind of relearning what normalcy is important. So it's, I think, important as a physician too, to kind of recognize that, and even as a medical student, kind of seeing those things and recognizing that those are big moments for patients that we might think of another day in the life of us, but for them it's huge. It's part of their healing process.
Yeah, it's definitely true. So in regards to your current program at UNC Chapel Hill, could you give us a quick rundown of your program curriculum from PGY-II to PGY-IV?
Yeah, absolutely. So I'm obviously finishing up my second year residency, my PGY-II year. So in general, for PGY-II year to start, it's pretty much we do all kind of adult medicine during our second year. So we do about 7 months of inpatient medicine. Typically, we do kind of 2-month blocks at a time. So we're not doing all inpatient kind of straight through. Currently, we have 3 kind of inpatient teams. That is going to be changing a little bit on our side just because we're expanding our rehab hospital. But in general, we have kind of our spinal cord injury service, and then our kind of neuro rehab, so our stroke kind of TBI population is another kind of team or service. And then our kind of third service is kind of our medically complex amputee kind of cancer rehab, kind of almost everybody else, so to speak. So as residents, we work, one-on-one with our attendings during the inpatient time. We, again, usually have about 9 to 10 patients on each team. And there's always, at least 2 second-year residents on, and usually early on in the I guess academic year, we have our, like a PGY-III or 4 kind of on to kind of be our senior to kind of help guide us through the process. And then in addition to that, during the second year, we also have about 5 months of clinic. So we have about 2 to 3 months of what's called our kind of general, like we call it just our general rehab clinic, so to speak. So we see patients from, amputees, SCI, TBI. We do spasticity management, MSK, ultrasound injections. So that's broken up basically throughout the day, about a half day each. You work a half day within a different attending, essentially broken up. So in the morning I might be doing spasticity management with Botox, and then the afternoon I'm doing kind of, ultrasound guided injections, so to speak. And what's unique for us is that in addition to the general rehab type clinic, we also get spine medicine exposure. So we get to do a lot with our, other PM&R kind of folks who do more with kind of the back pain management in general. So we get experience, doing, epidural steroid injections and all that stuff early on in our second year, which is great. It's fantastic, especially if you're thinking you might want to do pain or MSK in the future. You get early on exposure. So I think that sums up just about second year in general. And then third year is kind of a mix. So we do 3 months of pediatrics. So our pediatrics service right now is a mix of consults as well as clinic. So our chairman, Dr. Alexander, is also in pediatrics. So he does a really great job along with Dr. Barton, kind of spearheading our exposure. We don't have inpatient pediatrics at UNC currently, but I can tell you from the experiences from our upper levels that they feel like we get, enough exposure in pediatrics in general in terms of, feeling comfortable kind of, counseling families and patients and managing the acute kind of medical conditions. In addition to pediatrics, we do about 3 months of EMG. So we start that early on. And then it's kind of a mix. So you can kind of do 2 to 3 more months of inpatient medicine if you want to do more inpatient months like myself. You do have a month of like elective time as well as clinics. So you can do kind of the general rehab clinic or the spine clinic as well. And then we also get exposure into sports medicine as well. And then for fourth year, I know this is kind of a lot, but fourth year again is kind of a mix. So again, we do about 2 to 3 more months of EMG. So as a fourth year, you're kind of able to guide that third year resident that's new in the EMG lab to kind of teach them the ways and how to do things. And then we get a couple more months of inpatient medicine as well as kind of the general rehab clinic. And then we get a lot more elective time. So we have built in our schedule a couple months of consults as well as electives. So the consult, it's called, we don't really have a name for the rotation yet because it's changing, but we're calling it kind of consults right now. But typically with those rotation, you're seeing consults early, in the morning, helping like clear any admissions or anything like that. And then in the afternoons, you're kind of spending that time doing elective time. So if you want to go hang out cardiac rehab or P&O and get exposure there, you can do that, or wound care, all those things. And then I'm trying to think what else for fourth year. It's pretty flexible in general. So if there's certain things that you want to see or you want to tailor your, education for, we can do that for you because we're a smaller program. So I think that's it in a nutshell.
Okay. Sounds like a very nice and like well-rounded program where you can like
It
explore
is.
a lot of interests. Okay.
Yeah, it's nice for us that we're balanced. We still get a lot of that inpatient exposure even as a fourth year. So if you're somebody that wants to do inpatient medicine, and you're a fourth year and you don't feel like you're forgetting it all because you're still getting a couple months and you can do more if you want, as well as getting that consult exposure too. And then a big plus too is getting that early spine exposure as a second year with additional months built into your electives if you're interested in kind of going down that kind of MSK pain, spine route.
Okay. Awesome. Can you describe a typical day of a PM&R resident and what I guess the typical call schedule is like for you?
Yeah. I know this probably varies program to program, but in general, so on inpatient medicine for us, it's Monday through Friday. We'll kind of discuss the call schedule in a little bit and what that all means. But for us, we typically we don't pre-round, we just chart check. So we try not to wake up the patients more times than we need to, just because we recognize that sleep is kind of important too for our patients recovering. So I typically get to the hospital around 7:15, 7:30, and I start kind of chart checking my patients, kind of seeing what happened overnight, looking at new labs, anything like that, kind of touching base with nursing. And at 7:30 a.m., usually the resident that's on call will call in and kind of let us know of any overnight events, things that happened, if anybody was sick and transferred off, etc. And then from about 8 to, kind of varies, 8 to about 10 a.m., the attendings come in and we're, one-on-one rounding with the attending, with seeing all of our patients. Sometimes we're chasing them down in the rehab gym or something like that, but we spend the time kind of talking to them, trying to, touch base with families. And built into that, we do have what's called team conference, where we touch base with kind of our therapists and nursing staff during the week as well. So then, after we finish rounding, that's kind of our time to kind of, again, put in any orders, call any consults that need to be consulted. Obviously, you want to take care of kind of the sick patients first and any discharges that are, for that day, because typically you know who's going to be leaving a couple of days in advance. And at that time, you're obviously working on your notes, finishing all your work there. And that usually takes me till about 10 to, noon, I guess, so to speak. I always try to take a little bit of a lunch break. I know some days are busier than others, but we always, at least in our workroom, are always pulling each other out to step outside and grab some lunch. We do have a lot of good food options too at UNC, which is a plus. And then between like 1 and 5, it's kind of, you're seeing your admissions, you're clearing admissions, admitting patients. Again, you're kind of following up on consults, kind of just seeing what happens through the day. Because obviously patients, their clinical status can kind of change throughout the day. So you're kind of dealing with issues there and kind of getting people kind of tucked in, towards the end of the day. So the resident on call kind of has a clear plan of what's going to be in place. And so that's pretty much, it's about 7:30 to 5 every day. We do sign out to our, the residents on call at about 4:30, 5 o'clock every evening. And usually we're pretty good about getting out of there, around 5 o'clock, and sometimes a little earlier if we need to sneak out for something, or if you've got a doctor's appointment, we're flexible like that too. And then for the clinic, so again, this general kind of rehab clinic as well as our spine clinic, again, like I said before, it's broken up. So we spend, it's broken up into half days, so to speak. So we're with a different attending physician throughout, each half day block. So, at the CRC or general rehab clinic, I could be, seeing our kind of TBI follow-ups in one morning. And then that evening I'm doing kind of SEI type care follow-up, or I'm doing, MSK, which can be challenging as a second year sometimes, because you feel like you're trying to remember all these different things. You get one thing straight and then you're on to the next thing. But it is nice moving forward when you progress through the year, because then you retain those skills and those knowledge, consistently. And same with spine clinic. It's kind of that same idea, with the exception of some of your afternoons or mornings are broken up to procedure days. So you're down in the procedure suite getting to do your injections and all that. And usually those days, it's all, again, Monday through Friday, about 8 a.m. to about 4:30 p.m. So that's kind of the general schedule. Obviously, when we're on different rotations like pediatrics or EMG, it's all, again, kind of that same, 8 to 5-ish type of schedule. Usually we're not there, crazy hours or late or anything like that. And then for our call schedule, so this varies a lot for a lot of different programs. Through UNC, because we are not a freestanding rehab hospital, meaning that our rehab hospital is attached to the main hospital, we're allowed to take what's called home calls. So we do our calls for kind of a week at a time. It's pretty much, Friday at 5 p.m. all the way until that next Friday at 8 a.m. So what that means is we have two kind of call people, so to speak. We have got our first call and then our second call. So our first call is usually always a second year resident. So somebody like myself, where if I'm kind of that first call, I'm going to be the first person that the nurses are going to be kind of calling me for if they have any questions or want to feel, there's something happening to the patient. They need me to kind of check up on things. I need to check up on labs. I'm kind of the go-to person. So for the most part, you typically don't have to go in, during the weekdays, overnight. It depends, patients are getting sick and you're not quite sure, you go in and check in on them, obviously, because you want them to be safe. You want, a plan to be in place. We also do have our ICU team that comes if there's like a very abrupt acute change, which is very helpful to kind of have your colleagues there to help field anything. So in general, I think during the week, I've only had to go in like once or twice, in the past, I think several months being on call to kind of check in on a patient. And then for the weekends, we go in and round. So we meaning the first call resident and then the second call resident, who is typically your upper level, your third or fourth year resident, along with one of the attendings that's on call. So we all go in and we meet up. It kind of depends on what time the attendings want to round, and we go in and kind of round, see our patients, do our kind of normal stuff, discharge, admit patients, all those things. And then we're usually done around 12 or 1 p.m. So kind of whenever the work is done, you can go home. And the nice thing about just having our call system the way it is that obviously with the second call resident, they're always going to be your backup. So if I ever had any questions or concerns, especially taking that first call, those first couple of weeks, it's a little nerve-wracking. You have somebody to kind of fall back on and talk to. Same with our attendings. I've definitely had a couple complicated like spinal cord patients and, picked up the phone and contacted our spinal cord attending, and she's had no problem, helping me kind of feel the situation. So, and in terms of frequency, we usually do about one kind of week of call about every month, so to speak. So you're working about one weekend a month.
Okay, that sounds great. Thank you. Can you tell me about your current research project in PM&R?
Yeah. So, because my interest is more in spinal cord injury medicine, I noticed a lot of people that were coming to us were being seen by our consult team and weren't having the correct kind of neurogenic bowel program adherence. So we would give our recommendations to the patient's acute team, and then they were coming to us where the orders weren't right or wasn't being followed appropriately, or the patient didn't really understand kind of what was going on. And we also noticed too, if our spinal cord injury patients ever got acutely sick and had to transfer back to the acute floor from rehab, that their bowel program kind of was just kind of falling off the wayside. And, as we learn, or many of the students, you guys will learn, is that, you know, it's important to kind of have a bowel program in place for spinal cord injury patients, because they're going to be at increased risk for medical complications, whether that be, autonomic dysreflexia, UTI, ileus, et cetera, skin breakdown, all those things. So there's no reason why we can't be, starting that process earlier, and not just waiting for them to come to our side when they've been in the hospital for several weeks. So what I did was I kind of initiated what's called kind of a bowel initiative. It's a quality improvement project, kind of the primary aim is just increasing the neurogenic bowel program adherence. So whenever we had our initial consult, our consult team would kind of come in and give our recommendations, but then that patient was kind of assigned like I called it a bowel resident, where that resident, typically it was the resident that was on the spinal cord surface on the floor, would kind of follow up on those patients on the acute side and touch base with the team and see if they've had any questions, help clarify orders and make sure that they're being done correctly. And also educating the nurses too, because we recognize that a lot of the nurses just didn't quite understand, how to perform the bowel program, or, what does digital stimulation mean? What does disimpaction mean? How do I do that? What time? What is this? Why is this important? So we kind of provided that education for them. And in a way to kind of measure that, obviously we get the patient feedback, the nursing feedback, but when patients would come to us initially to rehab in general, we'd always usually get a KUB, so an x-ray of their belly, just looking at stool burden. And it was an easy way for us to kind of quantify, patients that didn't have the initial kind of bowel program adherence versus the ones that did. Most of the time their KUB showed that their stool burden was less, and they had much less medical complications. So, things like ileus, things like autonomic dysreflexia, things like UTIs were decreasing. And then, even an additional benefit where these patients were learning more about the bowel program early. So they weren't spending as much of that time in rehab learning it. They were able to then learn how to do it independently sooner too, because they already kind of knew what this meant and had the process started. They were feeling better, so they're saying, "Hey, yeah, let's do this," and they were able to kind of learn more advanced skills while they're up in rehab with us. So I think in general, it's important, because it's, again, something that you don't think about. Oh, it's a bowel movement, but again, it's patients, especially with spinal cord injuries, when they're being admitted to the hospital, it shouldn't come with like an increased risk, knowing that if they're going to be admitted, that nobody's going to be able to do their bowel program or something like that.
Yeah, I actually really love that. It's very proactive, and it sounds like it's interdisciplinary, and you're partnering with the patient, and the outcomes are there. So it's making a big impact in, the patient outcome. So that's really awesome. So my next question is, we all know this is kind of a crazy time with COVID, and so many people are being affected, especially, medical trainees. So how would you say that COVID-19 has affected the field of PM&R in general, and given your perspective as a PGY-II, especially in training?
Yeah, I think obviously when COVID hit, it was crazy all across the board. So I think it definitely made some changes, or we had to make some adaptations to our learning in general as residents. But I think, as a whole, in terms of just how we care for patients, it's definitely forced us to kind of adapt. Obviously, with using things like telehealth and, all the virtual visits has really grown a lot with a lot of our patients, which can be very beneficial for patients with mobility limitations. If they can't get transport and can't be seen, we could do a video visit or touch base with them via phone. On the flip side of that, it also kind of highlighted some of those barriers with patients that maybe didn't have access to internet. And, for them, going to clinic was the right thing for them, because they didn't have access to internet and things like that. So I think, it helped us adapt, obviously, again, with, building more of our telehealth. And also just, I think COVID in general really reinforced the importance of PM&R, because, we're seeing obviously long COVID now and those long-term effects with patients. And there's been a lot of multidisciplinary clinics kind of opening up. A lot of them are through PM&R, because I think we're kind of, designed to, in our training, to spearhead the clinics where, we know how to work in teams, and we know how to kind of see the whole patient and how this affects their function with all their different side effects and things that they're experiencing post COVID. So it's not only just in the clinic itself, but also acutely when they're in the hospital of, hey, we're PM&R, but let's focus on, their skin, their bowel and bladder management when they're in the ICU, so we can prevent things like, skin breakdown or medical complications, or contractures and things of that nature. I think as a resident, obviously it was a little bit, I was an intern and things definitely kind of, you know, changed abruptly with my education. But I think our program in general, from what I've heard from our upper level residents, that, we were still able to kind of make the adaptations and see the patients and get the learning that we needed. We made all of our didactics virtual, and they're still ongoing as virtual, which again is kind of nice because as an intern, I was actually able to listen into those, and had more time to kind of, jump into those calls. And it also just allowed us to kind of reevaluate, how we deliver care to patients in general. So are we accessing patients how we need to be, or what's the limiting factor with all of them?
Okay, awesome. And my next question is, what have you discovered about the scope or practice of PM&R that you did not know before residency?
Oh gosh, I think in general, just how broad the field is. I know we all kind of know that, but I think seeing just the different attendings at UNC and how their day-to-day practice is so different from one another really kind of struck me. You don't necessarily think about it, about how you can be doing just spasticity management and seeing just concussion TBI patients, or you can be doing kind of a mix, or you can be doing just pain MSK, or you could be doing spinal cord injury with a mix of inpatient and outpatient medicine. I think I again didn't realize how well you can kind of tailor your practice in the future with your likes. And I think the flexibility, obviously you have to find kind of the right job that fits you, but the flexibility that the field offers is something that I didn't, I think, appreciate and recognize until I was really a resident, seeing what every different attending's doing. Because again, everybody's schedule is so unique, and types of patients they see too is very unique.
Okay, awesome. Yeah, as a student, I thought I had seen so many broad things, and then I keep learning about all these new fellowships, and I'm like, wow, there's another path that I could pursue if that's what I wanted. So open to so many possibilities.
And yeah, and there's so many different areas that are growing. Obviously cancer rehab is kind of one of those newer fellowships too that you hear about, and again, it's just there's so much that you can do.
Okay, great. So one of the issues that fourth year med students are facing right now is getting experiences in PM&R. We kind of talked about that a little bit earlier, and experiences working with different programs across the country, given like limitations with away rotations. How would you approach the problem now if you were in the shoes of a fourth year med student? Because you mentioned, you had kind of gone through something very similar to what students are going through now with COVID. So
yeah, I think, like I said, I had only done one rotation in PM&R, and that was kind of it for me. So I definitely feel that stress. I know it was really, really hard for me applying, because I felt, oh my gosh, is my experience adequate? Am I going to look okay on kind of the application in general? I'll start with, saying that I think obviously programs recognize the limitations on rotations and student experience. So we see it too. I know it's something that our program director brings up too, that, we see it. So, you're not necessarily alone in kind of, fighting this battle, so to speak, by yourself. I think things that students can be doing that would help is obviously, at the minimum, you need to get a rotation in PM&R and get a strong letter. But also, network is huge. So, attending meetings, whether that be you submit a poster to AAP, PM&R, or attend a mid-year meeting for AOCPMR. It's a great way to meet other PM&R physicians, just to chat with them, kind of pick their brain. And from that, seeking out kind of mentorship. It could be, again, with an attending physician. It can be with even a medical student that's the year above you, or residents too. There's a lot of great mentorship programs. I know a lot of PM&R residents like to mentor and kind of guide students through this process, because they can be somebody that you can kind of bounce ideas off of. They can look at your personal statement, your application, and just give you some general feedback. And then also just taking advantage of the virtual events too. So, I know last year there were a lot of kind of Instagram stories and virtual events that even through, Twitter and Instagram, in terms of just highlighting different residency programs. I know a lot of it can be time consuming and exhausting because you're sitting on Zoom every evening for, several hours, but it's nice to just kind of check in and just kind of, show your face, I guess, and just get contact info for those programs. And, with that, not being afraid to reach out to programs too. You can, reach out to the residents if there's something that you want to learn more about the program or just get to know. It goes a long way, because I know as a resident, if I've got students reaching out to me on Twitter, I think it's great to see, because one, it's nice to know that they're interested, and I'm always happy to help and guide them in any way I can. So I think those are kind of the big things. So, you know, networking and mentorship, I think, are the biggest things that I think when I was applying as well, I didn't really I figured that out kind of later in the application process about how important that was. So if you can be proactive in doing that, it goes a long way.
Yeah, I think that'll be really helpful for our listeners. And I know everyone is trying to get more engaged with Twitter and social media, and networking is how we found you as well. So I think it's a great tool.
It's great. I mean, Med Twitter is awesome.
Yeah.
I joined it this year, and I was like, man, I wish this was, or it probably was around when I was a medical student, but I didn't really have a Twitter account. I just, didn't think about it. And it's great. I mean, I've heard of people kind of getting, plugged into kind of research projects or other shadowing experiences or, events in a community. It's wonderful.
Yeah. So the next question I have is, in your perspective as a current resident, what are some important questions that you highly recommend students ask about residency programs during interview season?
I think obviously everybody wants to know about call schedule and all of that, but that's something that, you may or may not get from the program itself. But I think the things that are important outside of kind of the bread and butter questions and things that everybody wants to know is, one is, I think, diversity initiatives for kind of the residency program or residents as well, because I think it's important, as a resident, like, you want to make sure that you're representative based on kind of your background and, experiences as well, and making sure that, you're working with colleagues that are kind of similar to you, and making sure that they're providing you with not only you, but also even as far as going on to your patients with adequate kind of access to things, whether that be educational resources as well as healthcare. I think that's just important, just based on kind of the time that we're living in. Again, you want to make sure that you're in a program that's kind of representing you, and making sure that you feel comfortable being who you are in that program itself. Along with that, I think wellness in general, some people, like, for them, wellness is just for them. Hey, I've got an afternoon, I'm done in clinic earlier in the afternoon, I can just go and do what I needed to do. Other people think it's really important to have yoga kind of throughout the day or other events. So, making sure that there are kind of wellness activities that suit your need as a resident. It doesn't necessarily have to be, again, like a big, event for you. It's just something that would be helpful for you to kind of prevent burnout when you're going through your training. And then, having a program that, another question is, how do programs respond to resident feedback is big, because as residents, a lot of times we're at the forefront of patient care. So if there's things that we're seeing that, aren't quite making sense, or we're noticing, do you have somebody in your program that you can go to and talk to and, get things figured out, whether it be, again, with patient care stuff or just personally too. Because that's important, because this is, your training, and your training is going to be a reflection of how you deliver, ultimately patient care. And we want to make sure that we're doing the best. And in order to do that, you should be in a program that values your feedback and takes your feedback seriously. I think those are the big things. I think, getting a sense of what residents do in their free time as well. Just, again, making sure that you're kind of finding your group of people that you want to hang out with is important, because they're going to be your colleagues, but a lot of these people are going to become your friends too, because you're going through all this together.
So yeah, gauging like the culture of the program and kind of what they value and what they hold important. Okay, got it. Kind of going alongside that, what are some common mistakes that people might make that put them at risk of not matching into PM&R that you've personally seen or that you've heard about?
Yeah, I think, obviously everybody thinks, the board scores and all those things too. Obviously that's part of the application process, but I know with PM&R in general, we're a little bit more holistic in a way that we look again at the whole applicant. So board scores, test scores, grades are kind of one piece of the puzzle. We also look at your just experiences and rec letters. I think not having kind of strong letters of recommendation sometimes hurt people and put you at a little bit more risk with the match process, only because these are coming from other physicians that are well respected in the field, whether it be in PM&R or other specialties, that can really comment on your character, and that really gives, I think, people that are reviewing your application a sense of who you are as a person. How do you function as a physician, and are you somebody that really fits the program itself. I think that is important, and can be a common mistake, making sure you, when you're requesting those letters too, asking if the attending can write you a strong letter of recommendation, because those words kind of imply that, yes, this is important, this is my future. And because anybody can write a generic letter, but if it's just not really highlighting you appropriately, then that shouldn't be, used in your application. I think also is just not networking as well, as just kind of being isolated within the field. You don't necessarily have to go out and meet all these different, PM&R physicians or residents, but taking the time to kind of reach out to some programs or trying to get into those virtual events and, speak to some of those residents or attending, virtual meetings is important, especially now with the nature of how, applications and interviews are going on. And then a couple things I'm trying to think. Not prepping for interviews in general too is, I know it can be nerve-wracking, but taking the time to just sit in front of a camera and, getting asked questions and letting you just kind of learn how to, address those questions appropriately. It's okay to practice, and this is showing your personality too. Trying to think if there's anything else. So
navigating Zoom and the tech problems.
Yeah, it is. It's huge. I mean, I still am not used to the whole Zoom thing, and I find myself looking at the wrong part of the screen. So it's different. And again, we recognize that too. But just taking the time to, practice those interview questions and kind of get used to just talking about yourself, which is kind of weird too. Most people don't like doing that because it's just weird. It's not something we're used to doing. And then, the last thing is also just kind of showing your interest within the field. So again, it doesn't have to be that you did some crazy big research project, but it could be something that, hey, I got involved in my community, helping patients with disabilities doing X, Y, Z, and I did this volunteer thing, something like that, just to kind of show your overall advocacy and understanding of, seeing patients with disabilities and things like that is important, because we want to see that, obviously like the medical side of things, but, whole person. Are you somebody that is that fit for rehab medicine?
Okay, thank you. That was really helpful advice. So you're a very resourceful person with a lot of great insights into the field of PM&R, and I feel like our listeners have learned so much from you today. Where can listeners connect with you to learn more about future projects, or just connect with you?
Yeah. I'm on Twitter, as we learned. So you can always contact me on Twitter. My Twitter handle is at Dr Tompary. My last name is Tompary. And typically that's probably the easiest way to get a hold of me. I also have my email through UNC I can give you. It is my first name, Andriana.Tompary, and then it's at unchealth.unc.edu. So either or. Sometimes I have to say with UNC, our firewall, not all the emails go through appropriately. So that's why I always say Twitter first, just because I see all those messages. So if there's ever any questions, or you just want to pick my brain or help you out with a personal statement, reading that, reviewing, I'm always happy to do that. I don't mind mentoring and kind of guiding you. I can't say I have all the answers, but just enough to say that I've been through the process and, kind of know what it's like to be in your guys' shoes.
Awesome. Thank you so much, Dr. Tompary. This was so helpful, and it was amazing talking to you. I had a lot of fun doing the podcast. Is there any last-minute advice or information that you would like the audience to know that we haven't covered yet so far?
Oh, that's a good question. Good last one. In general, the only thing I have to say going out is just remember to kind of enjoy the process. I know as a medical student, even as a pre-med, it was always, oh, if I get in medical school, things will get better, or if I get through this rotation, things will, get easier. And things obviously do get easier as time goes on, but just try to enjoy those moments too. Like interviewing in general is obviously very stressful. But it's also an exciting time where you can, kind of, explore different areas of the country and, move to do different areas and just meet a lot of great people. So try to enjoy the moment again, because I think even myself as a medical student, I was so focused on that next step that sometimes I forgot to just stay grounded and enjoy where I was now, because you're never going to experience these things really again. And things are always changing with how you're training and everything like that.
It's good advice for an incoming fourth year who's a little bit stressed out. So that's great to hear. Good reminder for me. Yeah.
Deep breath.
Okay.
Okay.
Awesome. Well, thank you so much, Dr. Tompary, for the great insights, for speaking with me today. I really appreciate learning about your journey and learning about your program and all of your great advice. I just want to say on behalf of AOCPMR and especially the PR Council, thank you so much and have a great rest of your day.
Thank you. Thanks for having me.
Yeah, of course.